Hello there, my name is Robert Bradley. I'm one of the advanced clinical practitioners in the emergency department, and I'm here today to talk to you about STEMI and non-STEMI, what the difference is between the two, and how do we identify them. So, cardiac chest pain. So it's quite important to get a good history. As a medical professional, I like to use the Socrates model, which stands for site, onset, character, radiation, associated symptoms, timing, exacerbative factors, and severity. So it's very important to get a good history take, and you can do this really quickly. So the site tends to be retrosternal or epigastric. They tend to actually, they don't point to it because it's not usually in a specific place. They go, the pain is here. So it's the whole chest or part of the whole chest. It tends to be tight or crushing in nature, or heaviness, people describe it as. It radiates across the chest into the arms, shoulders, neck, or jaw. Doesn't tend to go at the back of the neck, but mostly the front, the anterior part. So it can, the symptoms, it can cause sweating, nausea, it can make them vomit, can make them collapse, and they tend to be quite short breath when it comes on. Um, there's lots of debate about chest wall tenderness. It does mean it's less likely if the chest wall is exquisitely tender to be a cardiac chest pain. However, some studies have said that 12 to 17% of myocardial infarctions have chest wall tenderness. So you do have to err on the side of caution, especially if their risk factors are high. Risk factor wise, you can use something called the heart score, or the TIMI score. These are really good at actually predicting cardiac events. So if you have a high heart score, you're more likely to die basically from a myocardial infarction in the near future. So anyone with a high heart score should be seen by the cardiologist before they go home. And things like pain on deep inspiration tends to be less cardiac in nature. It tends to be more respiratory, pleurisy or fluid in the lungs or infection. And obviously, if they come in with a temperature, then it would tend to lead you away from thinking about myocardial infarction. So I thought it'd be interesting to talk about phases of an ST elevation myocardial infarction on an ECG. This is the thing that people always get irritated by clinicians asking for repeat ECG. So the reason is at phase 0, you could basically say there's nothing wrong with that. Maybe the T wave's a bit high. Possibly you could be thinking that they could have a high potassium level. You may well not consider that any finding whatsoever. You just sign it as a normal sinus rhythm. And then in phase 1, you can see there's some ST elevation starting to show. So this can happen within minutes. This is the problem. So this is why we ask for it to be repeated in 15 minutes. So it's a really good indicator. If they're early stages of an MI, then they may have a completely normal ECG. As you can see, phase 2, phase 3, phase 4. So if you catch the STEMI too late, so they come in 1 or 2 days later, it virtually goes back to normal. No ST elevation, no ST depression, and the T wave comes back positive again. So again, it can leave you down the wrong road. I thought this slide was quite an interesting one, because so which one is having an MI? So as you can see in the top image here, we have a normal sinus rhythm, and in the bottom image we have ST elevation in leads 2, 3 AVF, V5 and V6, and ST depression in V1, V2, V3, and V4. So not good. So actually, this is the same patient just a day later, which is this is why it's so frightening. It's why you have to get the history so correct. So this is patient on day 1, patient returned on day 2 with a massive STEMI. Okay. So this slide just shows you basically what we're looking at when we're looking at an ECG. It indicates which part of the heart is affected. So if the ECG shows ST elevation or massive depression in leads V2, V3, and AVF, then we're looking at an inferior heart attack. Okay, if the ST elevation shows up in leads 1 and AVL, we're looking at a lateral heart attack. Anterior septal is V1, V2, and anterior apical is V3, V4, and anterior lateral V5. So ST elevation MI. So a ST segment elevation MI is definitely the most serious. It means that there's been a very long interruption of blood supply. There is a complete blockage of the coronary artery. So depending on whereabouts on the ECG you see the elevation, depends on which coronary artery is affected, and it will help the cardiologist to know where to go, basically. So obviously, the longer you leave it blocked, the more damage that gets caused. We have several ways of intervening. One is thrombolysis, which was the old-fashioned way of doing things, and obviously the new way is putting a stent in to reopen up that blood supply. So obviously both have very serious implications, both of which you can die from. So it's a pretty major thing. So a non-ST segment elevation myocardial infarction is when your heart's need for oxygen can't be met. So it may have caused some tissue damage already to the heart, but usually only partial, not full thickness tissue damage. As the name suggests, there's no ST segment elevation. So when you're looking at the S and the T wave, it's not elevated on the ECG. There can be some subtle changes on the ECG, such as T wave inversions, ST depression, or biphasic T waves, which can be present in Welland syndrome and which can change very quickly. I've seen one when I worked in Peterborough as a gentleman, just had an ECG. He walked back to his chair, he's got chest pain again, and the HCA got a bit miffed when I looked at the ECG and asked him to repeat it straight away because the patient had developed pain, and all of a sudden he's having an ST elevation MI. So it changes very quickly. And so obviously non-STEMI is the one that you want if you're going to get one or the other, because early intervention can stop it going into a full-blown STEMI and causing full thickness damage to the heart. Then we have unstable angina or acute coronary syndrome. So you may have ECG changes, you know, like your ST depression, T wave inversions, and I think it's important to talk about what is angina. I mean, what is angina? So angina is actually defined as pain on exertion that resolves at rest. Okay, so they're exerting them, they're walking up the hill, they get this chest pain, they stop what they're doing, the pain goes away, and they carry on. So this is angina. Okay, so unstable angina is when these symptoms are happening very frequently, or they're happening at rest. So they're not exerting themselves. The pain is no longer going away at rest, and the medications, the GTN spray, aren't being as effective as they were before, and they're having to use it much more. Okay. Something important, so positive troponins are, the research says that they do equal a higher mortality rate. However, a negative troponin does not rule out acute coronary syndrome or unstable angina. I think that's probably the most important thing that I can tell you. So the history take is essential to get it right. Lots of things can mimic heart attacks, such as severe indigestion, costochondritis. You can get pericarditis, all sorts of different symptoms. So it's all based on the history. Um, okay, I hope that was helpful. Any questions, please fire them at me. Thank you very much. Goodbye.